Well, thank you all for joining. I think we're ready to get started here. My name is Jody Alwyn. I'm Professional Education Director for Resp. We are very excited to have all of you with us today to learn from Dr. Schwartz and Don Hefner on the physiology and follow-up of transvenous phrenic nerve stimulation. Before I pass it off to Dr. Schwartz, I'd like to go over a few Zoom logistics. I'm sure most, if not all of you, are familiar with Zoom by now, so please use the Q&A button usually found at the bottom of your screen to ask a question. There are quite a few of you on this call, so we'll do our best to address your questions. The raise your hand feature will not be active during this webinar. Also, this webinar will be recorded and will be available in a couple weeks, so please reach out to your Resp rep if you are interested in a copy of this. Dr. Schwartz is a sleep pulmonary physician and a retired professor of medicine from Johns Hopkins University. He is currently a clinical associate professor at Perelman School of Medicine, University of Pennsylvania. He is a clinician scientist with expertise in developing medical devices and digital technologies that address a broad range of sleep and breathing disorders. Dr. Schwartz is currently focused on applying low and high-tech solutions to sleep and breathing disorders for patients and populations in both the developed and developing world. Also, I'd like to introduce Don Hefner, who is a field clinical engineer for Resp and just celebrated his 11th anniversary with the company. He was instrumental in the clinical trials and has been involved in probably over 200 remedē implants and easily 1,000 plus follow-ups. All right, Dr. Schwartz, I will pass the mouse is all yours.
Thanks so much, Jody, and thank you to all of you who have organized and to the attendees as well. I'm going to be talking for just a few minutes about physiologic responses to phrenic nerve stimulation in central sleep apnea and Cheyne-Stokes breathing. By way of disclosures, I should mention that I am, if I can move the slides, for some reason, here we go. Okay. By way of disclosures, I have been involved with a number of different pacing technologies for respiratory applications, and particularly sleep and breathing problems, hypoglossal stimulation for treatment of obstructive sleep apnea, and more recently here, phrenic nerve stimulation for treatment of central sleep apnea, including my involvement and association with Resp itself. I'm trying to advance the slides. Okay. What I'd like to cover this evening is really three main topics. One is a brief review of sleep apnea pathogenesis in patients with central sleep apnea and Cheyne-Stokes breathing. And the reason for looking at this is that there's a lot of physiology that's embedded in the sleep studies themselves that really gives us clues as to the pathophysiology, pathogenesis of this disorder, and what therapeutic options exist. We'll also then speak about insights that we have gained into underlying physiologic mechanisms from the pivotal clinical trial and the feasibility studies that led to FDA approval of the remedē device. And then we'll take a slightly deeper dive into the underlying physiologic mechanisms for responses in Cheyne-Stokes and central sleep apnea to phrenic nerve pacing, so that at the end, I hope that we all emerge with a slightly better understanding of how phrenic nerve pacing actually treats patients with Cheyne-Stokes breathing and central sleep apnea. Well, let's look at the physiology of this disorder, and the physiology is disclosed primarily through the overnight sleep study. And shown here is several minutes recording from a patient who has typical Cheyne-Stokes respiration. As you can see, airflow, the middle tracing, shows the discrete apneic episodes that are punctuated by hyperpnic periods in which ventilation is waxing and waning in between the apneas. And in addition to the airflow showing this waxing and waning pattern of ventilation, we see the same thing happening in the oximetry and the thoracic and abdominal effort gauges. Essentially, what's happening here is that as patients go off to sleep with this disorder, they lose their drive to breathe and develop a reduction in ventilation, which constitutes a disturbance. And in response to that disturbance, the brain reacts with an overshoot response. Now, the reasons for this happening in many patients with Cheyne-Stokes breathing really have to do with a prolongation of the circulation time. And shown here, we can easily measure the circulation time on an overnight sleep study recording. The transit time, or the circulation time, is literally the time it takes for reoxygenated blood to come through the pulmonary circuit and left heart and be sensed in the oximeter in the finger. And that time is shown here, that with the resumption of breathing at the end of one of these apneic episodes, it takes about 36 seconds in this patient for blood to transit from the lungs through the left heart and to the finger oximeter. And it's only after this transit time that you see a resaturation occurring, a recovery in the oxygen saturation. Now, a transit time of 36 seconds is roughly double, a little bit more than double normal, which is about 15 to 17 seconds. And so this is an easy measurement that we can derive from the sleep study that gives us some indication as to why a patient might have Cheyne-Stokes breathing. But there are several mechanisms of Cheyne-Stokes breathing in addition to the circulatory delay. And they're all depicted here on this one sort of stylistic example of a Cheyne-Stokes breathing pattern. You can see the airflow trace in the top here, which again shows the episodes of apnea punctuated by the waxing and waning periods or hyperpnic periods in between. We commented that circulatory delay is oftentimes prolonged in a patient with Cheyne-Stokes breathing. And that leads to a mismatch between the changes in oxygen and carbon dioxide tension in the central circulation and what the brain and the respiratory control centers is actually seeing on a moment-to-moment basis. And it's because of that circulatory delay that the signals that occur in the lungs are delayed in getting out to the brainstem, where ventilatory control and respiratory pattern is being generated. That delay leads to the mismatch that we show here, where at the start of the apneic episode, the blood in the central circulation shows us a rising level of CO2, shown here in the red curve. But because of the prolongation in the circulatory delay, the rising CO2 takes longer to hit the brainstem and stimulate breathing. And so as a result, the disturbance in ventilation, in this case, the loss of ventilatory drive at sleep onset, leads to a stimulation of breathing that is much delayed. And that leads to this overshooting and undershooting. Now, the delay itself can also be caused by a second underlying factor, and that has to do with increased sensitivity of the respiratory control centers. That's shown here in B, where an increase in sensitivity to oxygen and CO2 stimuli is enough to cause greater hyperpnea in between the apneas, and that hyperpnic phase actually leads to a blowing down of your CO2 levels that actually begets the next apnea. Ventilatory sensitivity can be exuberant, particularly under conditions of hypercapnia or hypoxia. A typical example of hypoxia would be ambient hypoxia at altitude, which leads to increased ventilatory sensitivity and an increased tendency to develop central sleep apnea. But we also see that increase in ventilatory sensitivity when patients awaken or arouse from their apneic episode. And those sleep to wake transitions can be associated with an exuberant ventilatory response that leads the individual to blowing down their CO2 to the point that their CO2 goes so low that it crosses below the third factor, and that is the apneic threshold. And when we breathe too much, we have too much ventilation, we blow down our CO2 to below the level that is required to stimulate breathing. And so it's increases in the apneic threshold that also can lead to this start-stop or central sleep apnea pattern that we see. And as a result, we've got really a heterogeneous pathogenesis of central sleep apnea and Cheyne-Stokes breathing. And it may be hard to partition the exact mechanisms in the individual patient that we're treating. One of the things that we've noticed is that we actually can overcome this problem, not by, go back a slide if we can. Okay. We can overcome the problem by actually preempting the disturbance in ventilation that gets the cycling going. And so phrenic nerve pacing is a treatment modality that operates upstream to these three underlying or fundamental physiologic mechanisms. It is a fully implantable system in the hands of as embodied by the remedē system. It's designed to treat moderate to severe sleep apnea by driving inspiration and activating the diaphragm to do so. You'll see that it's automatically turned on at night, and it has three components that Don Hefner will describe, I'm sure, in greater detail. The pulse generator, the stimulation lead that stimulates the phrenic nerve, and a sensing lead that helps to optimize the therapy. This modality really essentially asks the question, if we preempt the disturbance in ventilation by stimulating instantaneously, can we capture the diaphragm and take over the breathing pattern? And the insights, the initial insights that we gained that this is actually the case, really came from the remedē feasibility and pivotal trials over the past 5 or 10 years. Because these trials, although they were primarily designed to address treatment mechanisms, we really gleaned a lot of physiologic insight from these trials that gives us some important clues as to how the phrenic nerve pacing device actually works to treat Cheyne-Stokes breathing and central sleep apnea. The largest of these trials is the pivotal trial on the remedē device itself, in which patients with Cheyne-Stokes and central sleep apnea were implanted, randomized for 6 months to either treatment or control. And those who were randomized to control, deferred therapy, therapy was turned on at 6 months and maintained for a total of now 24 to 36 months. We see that with this treatment modality, as you look at sleep disorder breathing event indices on the y-axis against the time point that patients were enrolled in the trial and treatment was turned on, we see a full 36 months of ongoing follow-up of all the sleep disorder breathing indices that we might be interested in. And what we see in the aggregate is that the improvement in every sleep apnea metric with phrenic nerve stimulation is due to a drop in the central component, the central apneas, not necessarily the obstructive ones. And so what we see here is really right at the onset of therapy, the central apnea index goes down, and it stays down at negligible levels for the entire night. And the magnitude of this drop in central apnea index, shown here, is exactly the magnitude of the drop in the overall AHI and in the oxygen desaturation index. But the magnitude of that drop also drives a drop in the arousal indices, in that arousal index also goes down by a commensurate amount and stays down right in parallel with the central apnea index. The implication here is that if we can treat central apneas, we can treat sleep disorder breathing, we should be able to decrease the arousals from these events, improve sleep quality, and as sleep quality improves, see improvements in daytime function and overall quality of life. And in fact, that sequence was shown here, where what we see in these patients who were enrolled in this trial is that compared to baseline, the arousal index goes down by more than half as a result of the phrenic nerve pacing treatment. and all measures of sleep architecture improve, with increases in deeper stages of sleep, both non-REM stage 2 and 3, at the expense of reductions in non-REM light transitional stage 1 sleep. And even REM sleep improves by a measurable amount at the 2-year time point compared to the baseline. So what we're seeing here is just by pacing the phrenic nerve, capturing the diaphragm, we're able to treat the sleep apnea, improve the sleep quality, and in the next slide, the downstream result from those improvements is less impairment of daytime function. And that's represented by an improvement in the Epworth Sleepiness Scale and improvements in overall quality of life, measured here by the Patient Global Assessment. So once again, the data in the therapeutic trial are really pointing us well upstream to the problem of apneas and hypopneas. The issue is, can we capture the diaphragm? And if so, how do we do it? Because that's going to be the key to treating central sleep apnea and Cheyne-Stokes breathing on a physiologic basis. If I were to state this in a slightly different way, if we can treat a breath, then we can treat an apnea, and we can treat a night of sleep, and we can maintain sustained improvements in sleep quality and in quality of life over a very prolonged period of time. Well, how do we do that? And the key really has to do with how does pacing the phrenic nerve lead to improvements such that we're able to capture the diaphragm promptly and pace the diaphragm on a sustained and repetitive basis over the course of the night. Because if we can solve that problem physiologically, then everything else is downstream, including all of the mechanisms for central sleep apnea and Cheyne-Stokes breathing that we reviewed, as well as the sleep continuity and daytime dysfunction. Well, the physiologic mechanisms for the treatment response really stem from an older study that we did a number of years ago with some Australian collaborators, in which we actually paced the phrenic nerve for a period of about 30 or 40 seconds, shown here during sleep. Now, if you look at the airflow trace on the top panel, you'll see that the patient is breathing normally during sleep. When we turn on the phrenic nerve pacemaker, we're actually stimulating the phrenic nerve for 40 seconds in this case. You can see that the lungs inflate, as shown here by the respiratrace signals. And as the lungs inflate, what we see here is that respiratory effort and all airflow ceases. In other words, we've captured the diaphragm. After all, that's how the lungs inflate. But we've also, in the process, induced an instantaneous, spontaneous cessation of respiration. We have ceased or suppressed the patient's own spontaneous respiratory efforts for a period of at least 5 to 10 seconds. Well, that becomes the key, because if we do this and there's an instantaneous response to stimulating or capturing the phrenic nerve, then the rest is all downstream. And that's shown here on an example of a polysomnographic recording over several minutes in a patient who is being treated with the remedē phrenic nerve pacing system. What we see here is in the middle portion of this panel, we're actually stimulating the phrenic nerve on a repetitive basis. So now we're stimulating for a burst of just a couple of seconds, rather than for a prolonged burst, as we saw in the last slide, of 30 to 40 seconds. And what you see in this individual in the middle of the night while he's sleeping, before we turn on the pacemaker, before we start pacing the phrenic nerve, we see the typical pattern of repeated Cheyne-Stokes breathing episodes with desaturations and hyperpnic periods. But the moment we turn on the phrenic nerve pacing system, we've captured the diaphragm in large part because we've managed to suppress the spontaneous output from the respiratory signal system as the lungs inflate. we've suppressed the spontaneous efforts that are generated by the ventilatory control centers in the brainstem. And that each and every time we've captured the diaphragm, we've suppressed spontaneous respiration and managed to entrain or pace the diaphragm in a periodic and repetitive fashion that ends up maintaining ventilation, as we see with the airflow recording, maintaining oxygenation. Sleep architecture becomes undisturbed by the Cheyne-Stokes cycles, and all is well and good. The moment we turn off that phrenic nerve pacer, as you see here at the end of this 5 or so minute period, the cycle resumes once again with Cheyne-Stokes breathing cycles that recur instantaneously. The moment we are no longer inflating the lungs with the phrenic nerve pacing system. Now, the reason that we are able to succeed in capturing the diaphragm and pacing ventilation really has to do with the interaction between our phrenic pacer and the body's own intrinsic respiratory feedback mechanisms. Because every time we capture ventilation by stimulating the phrenic nerve, the diaphragm goes down, the lungs inflate, and as the lungs inflate, there's an inrush of air that fills the lungs. And there are receptors throughout the tracheal bronchial tree and the lungs and chest wall that sense the fact that the lungs are inflating. In this case, we're doing it with our phrenic nerve pacer. But because of these receptors feed back instantaneously information that tells the brain and the respiratory control centers we no longer have to breathe in. The lungs are fully inflated, and in fact, this is a wonderful mechanism to prevent us from popping our lungs every time we take an inspiration. But as a result, we're able to tee off this mechanism because our phrenic pacer inflates the lungs. The receptors feed back to the brain and inhibit the brain's own spontaneous respiratory pattern generation. And as a result, it becomes much easier for our phrenic pacer to entrain ventilation and maintain a constant, steady, and stable respiratory pattern over time. And so the mechanism that occurs is really as a result of the success in initially capturing the phrenic nerve and inflating the lungs, and the feedback to the brain that allows us to repeatedly pace the diaphragm on an ongoing basis, thereby stabilizing ventilation. Well, from these physiologic mechanisms, I think we can draw 3 basic conclusions. The first is that we've learned that there's a complex interplay of physiologic factors that actually lead or play a role in the pathogenesis of Cheyne-Stokes and central sleep apnea. And these factors include circulatory delay, increased ventilatory sensitivity, and an elevated apnea threshold. The remedē phrenic nerve pacing system results in prompt, durable reductions in central sleep apnea and Cheyne-Stokes breathing that account for overall improvements in sleep disorder breathing, in sleep quality, and in daytime function. But we've also learned by taking a bit of a deep dive into the physiologic recordings over the course of the night that phrenic nerve stimulation can instantaneously capture the diaphragm, inhibit our own spontaneous respiration during sleep, and pace the respiratory rhythm thereafter. Well, these physiologic insights have distinct and direct clinical implications in terms of how we deploy the therapy. Because as we listen to Don in the next few minutes, we want to bear in mind that the physiologic mechanisms or the responses to phrenic nerve pacing will be most effective when our stimulator fully inflates the lungs. And Don will help us think about how do we get that kind of lung inflation that will allow us to capture the diaphragm and entrain the ventilatory pattern. Well, the lungs can be most effectively accomplished in patients without upper airway obstruction during sleep, or those who have really more purely central and Cheyne-Stokes breathing than a mix of central and obstructive episodes. Or simply by preventing upper airway obstruction from occurring during sleep with adjunctive maneuvers such as postural therapy or oral appliances. But we can also inflate the lungs best by up-titrating the stimulation amplitude on our phrenic nerve pacer. And to do that in such a way that we're sure to capture the diaphragm and entrain respiration along the lines that we've just discussed, with the physiologic interaction between our pacemaker and intrinsic physiologic mechanisms that allow the entrainment process to occur. Well, I'm going to turn the baton over to Don. We're going to hopefully talk about the details that will allow us to deploy the therapy in a thoughtful and effective way.
Thank you, Dr. Schwartz. You've wonderfully laid out the mechanism for us, and I'll pick that up and talk a little bit about what to expect. And really from the time a patient is implanted with the remedē system, the patients will leave the implant lab without an active therapy, and they need to be brought back at a subsequent visit. And so I'll share a little bit about the timing, the procedures involved in this visit, and then really I'll spend more time on the diagnostic data that the remedē system allows us, and how that guides us through optimization of the therapy and through the routine follow-ups as the patient moves on. It can be helpful to think of the follow-up experience really in three phases. The first of which is that activation of therapy, followed by a period of acclimation where we are optimizing the therapy and individualizing the settings for each patient. And once we feel the patient's stable, we'll move on then to a chronic routine follow-up schedule. Let's focus first on the therapy activation. As I mentioned, these patients are leaving the implant lab without active therapy. They're in fact in a monitoring mode that allows the remedē system to capture some data around their individual habits, sleep habits, activity, posture. And that gives us some insight into each patient and allows us then to set up the device early at this initial visit with a good mindset that the therapy will be effective for them, some margin of effectiveness out of the gate. And now the one note is that this is a therapy that patients will feel, and so there will be some acclimation to progress towards more effective levels. This initial activation visit is done in an office setting, can be either in a sleep clinic or in a cardiology clinic. We have programs with both. The visit itself can be on the longer side, and we tend to block at least an hour for this initial visit. There's a large amount of testing that occurs at this one visit that we won't be repeating at subsequent visits. The note also here is that patients that have a concomitant cardiac device implant, we're going to want to repeat some of the interaction testing that would have been completed at the implant to really confirm that nothing has changed and that it's safe for these two therapies to operate together. In order to do the testing and the calibration of a posture sensor, we do need a flat surface for these patients. That's easy in the sleep clinic with a bed. In the cardiology clinic, we're going to need either an exam table or a lie flat recliner to really get these patients into what we would expect to be a sleeping posture for them at home. The goals of this first visit is largely centered around stimulation. And we've just looked at the mechanism and wanting to understand which electrodes from the implanted system, these are multipolar electrodes, and so we're making an assessment based on what's available as to what subjectively it produces a nice, full, strong breath, what's comfortable for the patient, and is also what is using the least amount of energy to promote battery longevity. During that testing, we're identifying what levels are first producing some activation of the diaphragm, but we're more concerned, as Dr. Schwartz laid out, the stronger pulses, more moderate and strong, still in the comfortable range and not uncomfortable by any stretch, but we understand that these are where we'll be most effective with the therapy. There are some considerations for automaticity, and certainly some questions, Q&A with the patients, and some instruction with them on what controls they have. I'll get into more of that and the final programming ahead. The first step of this visit is to download that data has been captured. We talked about that 4 to 6 week stretch following implantation before we're scheduling this activation visit. There is some posture and activity data that will help us determine an appropriate therapy schedule for both the start and stop times. We'll look at also a concept we call the pitch or pitch threshold. Now, this is really the angle of the device that's implanted in the chest. And we'll look at that angle in relation to a supine position, or close to 0 degrees, versus an upright position, might be 90 degrees. We'll set a threshold in between those two that suggests that this is an appropriate sleeping position for a patient. It allows us to then accommodate patients that are lying flat with a single pillow, or those that maybe be sleeping in a recliner at a more elevated position. We'll also use some of that data that's been collected to look at what the resting respiratory rates are. That allows us to set up our stimulated rate and allows the opportunity for us to entrain the diaphragm with a stronger stimulation pulse. Again, we're selecting those initial therapy settings based on that data and repeating that cardiac interaction testing, cardiac device interaction testing, should it be required. There's also some housekeeping items, of course, parameters and saving of the data. Following that activation visit, the patient is going home with a therapy that is somewhat less than effective. And there are some automaticity features in the device that will periodically increase the outputs over the weeks following activation. We generally set up these titrations to occur over a course of 4 to 5 weeks, and we'll want to bring the patient back into the clinic again at that 6-week point, or at least 6 weeks, to allow some time for that patient to acclimate to that increasing energy and allow them to become comfortable with it as they enter into the clinic for the next visit. So this will be our first chance to optimize the therapy, and we'll certainly be interested in the patient's experience with the therapy. We'll look for opportunities to increase the effectiveness, and we'll introduce a decision tree here to guide our decisions on when we want to see that patient again. This visit is quite a bit shorter than the activation visit, although depending on the amount of testing or changes that we make, we generally are in the 30 to 45 minute range. The goals of this first optimization visit are really to understand from the patient how are they sleeping with the therapy. Are they able to return to sleep should they waken during the night? Are there postures or sleeping positions that may be more or less comfortable than another? And all of these questions that we'll be asking will help us give us some insight into what changes may be warranted to improve the acclimation or the comfort of the therapy for the patient, and in turn improve the effectiveness of the therapy. The diagnostic data really opens up at this point. Now that we have therapy being delivered, there's a large amount of efficacy data that will help us, again, guide the optimization of this therapy. We'll get a chance to review whether the start and stop times we selected are appropriate. We often see patients already beginning to have some changes to their sleep hygiene, and there may be opportunity to increase the time therapy is delivered, or perhaps patients are maybe a bit anxious and staying up late and feeling the therapy start. And all of these are adjustable with the programming system. We'll want to look again at the selected pitch threshold and ensure that it's appropriate for the patient's home environment. We'll want to make sure that we're not inappropriately inhibiting delivery of therapy. Should that patient add a couple pillows or again sleep in an elevated position. Of course, we're also looking, repeating our assessment of the stimulation thresholds with the electrode pair that we've chosen as best, and monitoring the lead impedance trends for evidence of stability with the implanted system. Based on this review, we'll make a determination on whether changes are required, and also making an assessment. I've got a flow chart here I'll show you in a moment on when we want to see that patient next. So I'm showing you here is our diagnostic reports, really remedē reports. And this is the download that we've taken from the device and presented to us in this way. The first screen we'll look at is the summary tab. It gives us a good insight and overview of the more pertinent program parameters, both within the therapy schedule, the configurations, and the stimulation. We also have a graphical representation of the battery, less important now in this early phase, but as time goes on in the chronic follow-up, it's a great quick assessment on where the battery stands. There are 4 tabs in this that are really critical in optimizing the therapy that I'll walk through. The therapy duration trend, the 24-hour pitch trend, our overnight efficacy, and the capture analysis trend. The first of those is the therapy duration trend, and this really is giving us a nightly data point of the durations of therapy being delivered each night. The maximum amount of therapy delivered is of course set by the start and stop times that we have selected for this patient. And most commonly, we're not delivering the absolute maximum. The therapy will suspend as patients change sleeping postures. It will suspend as they sit up and get out of bed if they're using the restroom in the middle of the night. But also, we can see less than maximal durations just on the daily schedule. If a patient is staying up late, for instance, or rising from bed early in the morning, each of these components will eat away from the maximum duration that may be delivered. What I'm concerned about in this early phase is any signs that the patient is having a challenge acclimating to the therapy. Are they shifting their sleep times from normally during the night to napping during the day more? Rare, but it's certainly something that we look for. In the legend, I have a couple toggle items that allow me to look at the actual times that are lost due to activity or rolls from say supine to a right or left position. And then also duration or therapy duration lost due to this violation of our pitch threshold. Really clues us in on to perhaps there's a programming change that's a result or why therapy durations are low. Generally, I like to see at least 75% of the maximum duration or higher. The next tab we'll look at is our 24-hour pitch. This is a 21-day trend with the median daily pitch values across a 24-hour window. The shaded portion is where therapy is active, and so I'll look primarily at this time frame. And what I'm looking to ensure is that while the patient's in a sleeping posture, that these median pitch measurements are well below the threshold. I generally like to see at least 10 to 15 degrees separation, and in this case, it's not quite that, maybe 5 degrees. So there may be some time lost just simply because the pitch threshold is selected too low. If the pitch then is ever above that threshold, then the therapy will be suspended. And as we see it here, this patient looks like they're waking up or rising out of bed or in the 7 o'clock range, and therapy will be suspended at that point until the next night, should they not lie back down. Our first efficacy trend is the overnight efficacy, and again, another 21-day average for us, and gives us 2 sets of data here. The first is our effectiveness in capturing or in training the diaphragm. And on the left scale, we're looking at the percentage of breaths during delivery of therapy that are entrained or are in synchrony with our stimulated respiratory rate. The second data point is our remedē respiratory index. And now this is based on our sensing electrode, and it's using transthoracic impedance and is monitoring for respiratory effort or movement of the lungs in particular. And what we're highlighting here are any 10-second pauses, 10 seconds or larger, which may be indicative of a central apnea. This is an example of a well-titrated patient. We see our tan line at the top is in the green zone, which indicates a good level of entrainment. Generally 80% or higher of the breaths are as a result of our stimulation. And a very low index, hovering right around 0 to 1 throughout the night. In the case where we don't see such a glowing report here, we'll want to dig in more deeply into the capture analysis trends. Now, this is where we see the effectiveness of stimulation in each of the different sleeping postures or positions, rather. This first trend is giving us insight in the all positions, and is where we start. On the lower scale, we see our current levels, and that tells us then at what current levels are we becoming effective with our stimulation. In this all supine, or this all positions trend rather, it's an aggregate data. What we'll do is move through each of the different postures, supine, right, left, prone, whichever the patients are spending the predominance of their time, and try to understand that our stimulation range, we turn on at a lower level and the device will automatically titrate up to a maximum allowable based on the programmed range. This will help us understand whether we need to shift that range or if we're already achieving the effectiveness levels that we're seeking. When it comes time to make a decision on where that next visit occurs, we've just completed our diagnostic review. We've spoken with the patient and made an assessment. Generally, at that first 6-week check following the activation, we're not optimized. We understand that we're also dealing with an acclimation component, and we're not yet at our targeted levels. We like to get to that point by the 12-week visit, and so we will make some changes and want to see that patient back in the clinic, generally in another 6 weeks. And that really brings us into our optimization, or the close of the optimization phase. We'll repeat this process until we get to a point where patients are stable and we feel the therapy is optimized. And so what does that mean? We're optimized based on what we see from the device and what we hear from the patient, but we'll want to confirm that with a sleep study, and that's generally either an HSAT or an in-lab PSG. We'll have a specific AHI target for these patients based on where they start before therapy, and use that as a guide to continue to push for greater efficacy. Once we get to a point where we feel the therapy is stable and optimized, we'll transition these patients then to what we consider the chronic or routine follow-up care pathway. These visits are then occurring generally every 3 to 6 months. Most patients are seeing on closer to the 6-month window, where these visits are much shorter in duration. We're again assessing any sort of symptoms that the patients may have, and really looking for any new or worsening symptoms that would indicate perhaps the settings are no longer optimal or something has changed. In most cases, we're providing fairly minor programming changes at this point. The therapy tends to be quite stable, and we'll again have our decision tree to help guide those next visits. As I said, visits occurring 3 to 6 months, and depending on the local standards. These are shorter checks. We're becoming mindful of the battery status levels as time goes on. The current generation of the device has a battery longevity just above 3 years, and so we're wanting to follow that as patients get close to that time. Much of the changes that we're making at this point tend to be schedule changes for patients. Either their sleep patterns are changing, or they're traveling. This is a time-based therapy, and we have the ability to accommodate travel across time zones, but we'll need to see the patient in the clinic to make those adjustments. Some patients may also request start and stop time changes based on the seasonal changes from summer to winter. As we get into this routine scenario, we're now looking at considering a study, an HSAT or a PSG, really only if we see significant changes or symptoms. Certainly, we have the opportunity to repeat those on an annual basis or as needed, but we allow this chart here to guide our decision making. Just a few final thoughts here before we turn it over to more of the Q&A. This system is really designed to be very flexible, and so there are a number of parameters that can be set, but the bulk of this work is being done at that first activation visit. That initial programming does require significant time. An hour is generally sufficient for those visits, but the subsequent visits will become shorter in duration. The routine visits, there is a simple checklist provided by the software to guide the user through the few steps needed to confirm stability of the system and to review the diagnostic data that has been captured since the last check. And then again, most of those changes that we're making during the routine checks tend to be minor in scale, schedule changes, time changes, these sorts of things. And that's really all I had here from the follow-up perspective, or really a glimpse into the pathway. And I will turn this back over to Jody and Robin and allow us to move through the Q&A.
Great. Thank you, Don and Dr. Schwartz. Wonderful. Appreciate your expertise. There are a couple questions that have come through. And again, if you have a question, please, on the bottom or sometimes top, depending on the system you're using, there's a Q&A box. Please type in your question. The one question, probably, I think it could be for both of you, but maybe Don. Are there concerns about the system inhibiting breathing?
Really, no. Inhibiting breathing, if you're thinking of the intrinsic respiratory cycle, perhaps, but the moment that we are providing stimulation and contracting the diaphragm, we are providing a very full breath, and we're able to slow down respiration. In fact, we set our stimulation rate at 2 breaths below the native inspiratory rate. Dr. Schwartz, I don't know if you have anything to add there.
Yeah, you have anything to add?
Yeah, we've thought about this quite a bit, and actually just published a case report where we actually compare the level of minute ventilation with the stimulator on and off. Now, with the stimulator off, the patient is having recurrent Cheyne-Stokes breathing patterns. But in the aggregate, the ventilation that we see off when the stimulator is off is identical to the ventilation that we see on phrenic nerve stimulation. The only difference is that the phrenic nerve stimulation maintains a steady respiratory rhythm, whereas the Cheyne-Stokes breathing patterns are obviously irregular and periodic. And so it's on that basis we've concluded that we are not overdriving ventilation, but rather we are simply capturing the patient's own ventilatory efforts. And the mechanisms are becoming clearer and clearer as we're looking at the transient on-off responses that I alluded to in the first talk. And that is that really the respiratory system is so tightly wired that it essentially is built in with intrinsic reflexes that make the brain's ventilatory control centers understand when it is getting enough ventilation or when it needs to actually breathe harder. And so what we're finding is that what we're doing with the phrenic nerve pacing is we're putting the respiratory control centers to rest. And as a result, we can maintain the same level of ventilation, but simply smooth out the respiratory rhythm. Now, as Don mentioned, the standard practice is to set this phrenic nerve pacing system at a rate that's 2 breaths below the patient's intrinsic respiratory rate, which is to say that we're able to actually capture the phrenic nerve without having to drive the respiratory rate up to very high levels. And that's by virtue of this very tight feedback loop where the brain recognizes that the lungs are inflating instantaneously the moment we trigger, the moment we stimulate. And it's as a result that the brain decides, in essence, to back off if the breathing is being taken over by the stimulator.
Okay, thank you. And here's another question, probably for you again, Dr. Schwartz. Does the diaphragm pacing increase obstructive apneas?
Yeah, no, this is the amazing thing. It doesn't look like it does. The data coming out of the feasibility and the pivotal trials is really crystal clear that we are not increasing the obstructive apnea rate whatsoever. We're treating the central apnea rate, and we're knocking that down to negligible levels. But we're not doing it at the expense of increased numbers of obstructive events. And that really suggests to me that we are really intervening at a level which is really upstream to all the other pathogenic mechanisms that we've described, that simply by stabilizing 1 breath at a time, we're actually able to stabilize the entire respiratory rhythm and prevent the periodicities. Now, important to recognize that the patients that are selected for this form of therapy have predominantly central apnea and Cheyne-Stokes breathing, not obstructive. And the entry criteria in the pivotal trial required that the total AHI, the proportion of obstructive events, obstructive apneas, was 20% or less than the total AHI. So by design, the therapy is really designed to treat predominantly central sleep apnea and Cheyne-Stokes breathing. But the other thing you should consider is that the patients that have been enrolled in our studies have moderate to severe central sleep apnea and Cheyne-Stokes breathing. In other words, we are really effective at a level of sleep apnea severity that is really quite difficult. And nonetheless, we're effective and therapeutic. And so I think we've really got a therapy that is tailored to the needs of the central apnea patient. But in addition, the therapy is invested with a number of other features that Don just described that ensure that the therapy will always go on as long as the patient is at the right posture or pitch within the individual's sleep window. And as long as those conditions obtain, the patient is inactive, in a recumbent position, and within the span of time that is considered to be his natural sleep cycle, this therapy goes on automatically. And as we could see from those polysomnographic recordings, it immediately and instantaneously treats the problem. So we're able to drive a level of therapeutic adherence and therapeutic effectiveness that is frankly so uncommon for all the PAP modalities for treating obstructive sleep apnea.
Great, thank you. Here's a question regarding the battery. Don, if the battery has only a 2 to 3 year lifespan, is the unit in a position to easily replace the battery? Are you looking into a longer life battery or considering a rechargeable battery?
So this is our first generation device that guided us through our clinical trials. The average longevity is 3 years, as I stated earlier. At maximal output, it can be as low as 2 years. It can also be as much as 5 years, depending on the programmable settings. Again, this is our first generation device. We certainly anticipate having improvements, second generation type systems, and I would fully anticipate the longevity to be improved in those subsequent generations.
Yes, thank you. And it looks like we have one final question, unless more come through, and we're at close to the top of the hour. So have you had to complete any device extractions? And if so, what were the reasons or patient complaints involved?
We have had a couple, and we had 2 infections, I believe, throughout our trials that were acute following the implant, and systems were removed. We do have some extraction experience with our leads to help guide our implanters, but it is a fairly small number at this point, still in the infancy of this therapy.
And it's pretty typical type, like with the pacemaker defibrillator type complications and issues that happen with any. Is that what you're? I mean,
that's
right?
a very good point. This is a transvenously implanted system, much like a pacemaker or implantable defibrillator is. We use the exact same technology, implant techniques and tools. So it's a very familiar profile that our implanters see each day with their cardiac therapy patients.
Yeah, and the implanters are electrophysiologists, correct?
That's correct, yes.
Yeah. So, great. At this point, I don't see any other questions. I don't know if anybody had any final words, but again, go ahead.
Jody, there's one in the chat.
Oh, it just came here. Sorry, I just got it. It must be a little more delayed. Do you have patients with CPAP for OSA, and is this device at the same time, and this device at the same time? In other words, dual therapy. Dr. Schwartz, do you want to take that one? CPAP for OSA and our device at the same time.
Yeah, not so much CPAP, but there might be a few patients in whom the device works for the central apneas, but they're still left with some residual obstructive apneas. As we said, we're selecting patients who have predominantly central sleep apnea, but they can have up to 20% of their AHI are obstructive events. In those patients, if they're symptomatic from the obstructive events, we might consider some sort of adjunctive therapy to treat the obstruction. But the therapy can oftentimes consist of positional maneuvers, pillows to keep them on their side rather than their back, or perhaps a dental appliance or other postural maneuvers. On occasion, you might find yourself resorting to CPAP, but I think that's the vast minority of cases. I think more to the point is in those who have residual obstructive events, they are oftentimes obstructive hypopneas rather than complete apneas. And the patient who has hypopnea can still get lung inflation even though his airway may be partially collapsed. When we stimulate him, we can still get the lung to inflate. And as a result, we are rather successful in taking over the breathing patterns, in stabilizing the respiratory effort. Even when they have a partial degree of upper airway obstruction, we're still able to stabilize them. And it's really for that reason, because of the predominance of obstructive hypopneas rather than apneas, that modest measures like positional maneuvers or a dental appliance may be sufficient to treat the occasional patient with residual events.
Great, thank you. And there's a couple more questions coming in. If the pitch is incorrect, but within the early thresholds, how does the stimulator affect breathing? In other words, how does pitch affect breathing, and why is it so important to titrate the pitch? Don, you probably want to take that?
Sure. Well, we use this measurement of pitch to allow us to understand what we feel is an expected sleeping posture for a patient. And so we're setting up this threshold where below which this threshold, the patient's in an expected sleeping position and therapy may be delivered. Now, if the patient is upright at some point in the night, this gives us the opportunity to pause and suspend therapy appropriately if the patient is upright or out of bed. And so we want to be mindful of setting a threshold that both allows appropriate therapy but prevents inappropriate delivery of therapy if the patient were sitting upright or, again, climbing out of bed. And so that's something that we monitor. And it's really, we want to be mindful of allowing for appropriate therapy and not inappropriately preventing therapy through a poorly selected pitch threshold.
Thank you. Here's another one. Is the goal of this therapy still the same as with others in sleep? In other words, bringing the AHI down to 5 an hour? Dr. Schwartz?
Sure.
Go ahead, Don, if you were thinking.
Please.
Yeah, listen, in general, we're treating patients with moderate to severe central and Cheyne-Stokes breathing patterns. What we find is that we're knocking the AHI and all the other sleep disorder breathing and sleep metrics down consistently. That although we may or may not get to a level of 5 an hour or below, we're really achieving substantial improvements in the apnea metrics, in the sleep architecture, and it's really as a result of those two things, the reduction in apnea rates, the improvement in oxygenation, and the improvements in the depth and quality of sleep, that we're seeing huge symptomatic relief. Consistent improvements in Epworth and quality of life measures. Most every patient that's had this implant is reporting and reported formally in the trial that if given the opportunity, they were asked the question in the trial, if given the opportunity to repeat the procedure and go through it all over again, 95+% of them said yes, they would. And so I think what we're achieving here is really groundbreaking for the Cheyne-Stokes and central sleep apnea field, primarily because we have not, to date, had non-invasive therapies that are so well accepted and drive such high levels of both adherence to therapy as well as effectiveness. And needless to say, ASV is off the table for many of the patients with heart failure and reduced ejection fraction because of the SERVE-HF trial. So we're really touching a number of different important indicators. Therapeutic effectiveness as well as adherence, the combination are really what it really constitutes the secret sauce that leads to marked improvements by every parameter as well as how people feel.
Yeah, the only thing that I would add there, Dr. Schwartz, you showed us some of the data that this system is remarkably effective at reducing central apneas. And so it really comes down to patient selection, finding the patient that we believe will benefit most from this and understanding what sort of residual events we might anticipate based on a patient profile presenting for implantation of the system.
Well, excellent. Thank you very much, Dr. Schwartz and Don. It was an excellent discussion, and I know I learned a lot. I always learn a lot from both you folks. And we are past time, so I appreciate you all joining, and thanks for the attendees as well. Have a good night.
Thank you, Jody.
Thank you.
Thank you all.